All right, so now we're going to start talking about our cardiac physiology. So we're here at 19.4. First of all, let's remind ourselves that our heart cells, our cardiac cells, have autorhythmicity. Remember, they are able to contract on their own. However, there are a lot of things that regulate this heartbeat. So they can do that on their own if they need to. So it'll keep beating at a regular pace, but the heart is actually regulated by and corresponds to outside influences as well. So we have neural influence, we have endocrine controls, and those are actually vital to the regulation of this cardiac function. So relying on the heart cells alone is possible for short periods of time, perhaps even long periods of time, depending on how stable a person is in general. But mostly what we really need here are neural and endocrine controls. Also, our heart is very sensitive to environmental factors, including electrolytes, and we'll take a closer look at that as well. So first, though, we're going to take a look at our output, our resting cardiac output. So we're going to take a look at some numbers here. And as we go into this, you do need to know the definition of each of these highlighted terms here, and you do need to know the mathematics that goes along with these. So you should know the averages here, and you should know how to do the math for these things. That is something you need to know for this section. So first, we have our cardiac output, or CO, which is a measurement of the amount of blood pumped by each ventricle in 1 minute. Okay, so cardiac output you can think of as an overtime type of thing. So we're taking an average overtime of 1 minute, and in 1 minute we're going to talk about how much blood is pumped out of the ventricles in that 1 minute. In order to calculate this, we are going to multiply our stroke volume, which, remember, stroke volume, or SV, is the amount of blood pumped by each ventricle. So that is just one single beat, though, so one single pump. Stroke volume is that 70-80 milliliters of that one single pump of blood, and the cardiac output then is measured over a minute's worth of time. So we're going to take that stroke volume, how much volume is pushed out in one contraction, and then multiply that by the heart rate. So how many times is it doing that contraction? How many pumps is it? So in contractions per minute or beats per minute, because it's in a minute time. So our cardiac output equals our heart rate, okay, beats per minute, times our stroke volume, which would be the amount of fluid. So that would give us the amount of blood pumped in 1 minute's time. So stroke volume is normally measured using an echocardiogram to record the EDV and the ESV. So remember the EDV, we talked about that when we talked about our ventricular systole. Remember, EDV is end diastolic volume. So that is the volume at the end of diastole. So at the end of the relaxation period of the ventricles. Remember, that's about 130 milliliters of blood in a resting adult. And our ESV, which is end systolic volume. So remember, that was the amount of blood, or the volume of blood in the ventricles at the end of systole, so after it has contracted, because remember, we only get about 70 to 80 milliliters pushed out, and so we had that 50 to 60 milliliters left in. And so then, of course, we just take the volume we started with of blood, 130, and then we look at the volume that we end with, and the difference is going to be the stroke volume, the amount that's pumped out. Also, our SV, our stroke volume, can be measured using a specialized catheter, but of course that's an invasive procedure, and it's more dangerous to the patient to have to go in and put a catheter and then watch the heart beat and see the volume, measure the volume. So a mean SV for a resting 150-pound person would be about 70 milliliters. So there are several important variables, and we'll talk about some of those. But some of them are heart, the size of the heart. So obviously, if you're a bigger person, so if we're talking about, some of the really, really tall people in this world, a 7-foot person, a 7 foot tall large person is going to have a bigger heart than, let's say, a smaller 4'10" person. So size of the heart. Physical and mental condition of the individual. Again, if If the person is incredibly overweight and has some other health issues, then there may be some plaque buildup, things like that that would make the size difference and the amount of blood that can get out different. Sex or gender, male versus female differences, contractility, so the stretchiness, duration of contraction, so how long the heart contracts, preload or the EDV, the end diastolic volume. So what it started with, if what it started with is different, then it would be a little bit different than that 70 milliliters. And then the afterload or resistance, so the resistance to pumping the blood. Again, that would be the case of somebody that has atherosclerosis, for example, and has a buildup of plaque in the aorta, for example. And then in that case, maybe there would be more resistance to that blood flow, and then therefore that would have a lower SV. Normal range for the SV would be about 55 to 100 milliliters. An average resting heart rate would be about 75 beats per minute, but remember it's the 60 to 100. So the range is 60 to 100 for heart rate. The range for stroke volume is 55 to 100 milliliters. Our average, our mean for stroke volume is 70 milliliters, and our average or mean heart rate is 75 beats per minute. So if we use those two numbers, the averages here, then what we would calculate is the cardiac output is about 5.25 liters per minute. So we're moving about 5.25 liters per minute of time with our heart. The range then would be about 4 to 8 liters per minute. So remember, however, that these numbers refer to our cardiac output from each ventricle separately, not the total for the heart. So we're just talking about one single ventricle separately. So the heart as a whole then would be double that because we see the same volume on both sides. So factors influencing the cardiac output are here. So these are some of the things, autonomic nervous system, innervation, so hormones, fitness level, age would all affect our heart rate. And then factors that affect stroke volume would be the size of the heart, fitness levels, gender, contractility, duration of contraction, the EDV, and then resistance. So we just briefly mentioned all of those things. So you should know that these are some of the things that would change the stroke volume. These are some of the things that would change the heart rate. And then, of course, the differences in heart rate and stroke volume are going to give us some differences in cardiac output. We also have one last kind of calculation in this section is what's called the ejection fraction. So that name is a bit misleading. Ejection fraction is actually a percentage. It mentions it down here. It's despite the name, here it is, despite the name, the ejection fraction is normally expressed as a percentage. So the ejection fraction is the portion of blood that is pumped or ejected from the heart with each contraction. So what we're doing is we're taking our stroke volume, the amount of blood that was forced out of the heart, out of the ventricles, and divide it by our end diastolic volume. And in that case, we get 55 to 70%. With a mean of 58%. Basically what we're doing there is rather than showing the volume of blood that's coming out of the heart, at that point what we're doing is we're comparing the amount of blood that the ventricle can hold and what percentage of that left, what percentage of that got ejected. So the ejection fraction is the percent of blood that was forced out of the ventricles compared to the whole, right, which was the EDV. Okay, so we eject, in general, 55 to 70% of our blood with each contraction, an average of 58%. Okay, so make sure you know the differences between all of those different terms, what they mean, and then also be able to do that calculation. All right, so exercise and maximum cardiac output. Here's just some general notes, I guess. In healthy individuals, heart rate may increase to 150 beats per minute during exercise. The stroke volume can also increase from 70 to about 130 milliliters due to the increased strength of contraction, so it contracting harder to get more volume out. This then, of course, would increase the cardiac output to approximately 19.5 liters per minute. So we're talking about a healthy individual that's exercising can actually pump through about 19.5 liters per minute compared to our average that we were just discussing with that 58%, or when we're talking about actual volumes, we were talking about that couple of liters there, that 55 to 100 liters for the stroke volume. And then when we were talking about the cardiac output, we were talking about the 4 liters to 8 liters per minute. So our average, I don't remember what the term is, or the symbol for average here. Average is about 4 to 8 liters per minute for our CO. And then when we're talking about a healthy individual that is exercising, they're bringing up their heart rate to about 150 beats per minute. Then we can get all the way up to this 19.5. So 4 to 5 times the resting heart rate. You can see that's even double the highest here, more than double. Top cardiovascular athletes can achieve higher levels, of course. At their peak performance, they could even do 7 to 8 times of that. Since the heart is a muscle, exercising it increases its efficiency. The difference between maximum and resting CO is known as the cardiac reserve. So it measures the residual capacity of the heart to pump blood. So if we look at the maximum CO, so the maximum cardiac output, so if your heart is at the max, the highest it can go to get the most volume out. And then we look at resting cardiac output, so just when you're laying on the couch, you've been laying there for a while, you're not concerned about doing anything else, just what the heart regularly pumps in the minute time, cardiac output. If you subtract those two, then you get what's called the residual capacity, or the cardiac reserve. So that's what your body can then use if it needs to. It's its reserve, its backup. Okay. All right, so heart rates can vary considerably, not only with exercise and fitness levels, but also with age. So a newborn resting heart rate can be about 120 beats per minute, and then it gradually decreases until young adulthood, and then gradually increases again as you get older. So due to, at the beginning, the heart is not as effective in a newborn. It's just getting started. Its increased heart rate is to try to make sure that it gets enough blood to the whole body. And then it becomes efficient. The body size is appropriate for the heart size in young adulthood. And the person is at its healthiest and strongest for its body size and age. And then it increases again with age, because then at that time the heart is getting past its optimum age. So it's going to be having a little bit more difficulty. It's having more resistance, because just over time, even if a person is healthy, there's going to be more resistance because we've used these blood vessels for many years now, and there's going to be roughening, and the blood may be thicker and things like that as we get older. So maximum heart rates, normally in the range of 200 to 220 beats per minute. Some extreme cases could reach higher levels. As one ages, the ability to generate maximum rates decreases, so the ability to get all the way up to that maximum rate is a little bit more difficult. This may be estimated by taking the maximum value of 220 beats per minute and then subtracting the individual's age, just flat out the age. So 40-year-old individual would be expected to hit a maximum heart rate of about 180 beats per minute. A 60-year-old person, maximum heart rate of about 160 beats per minute. So, again, take the 220 beats per minute, which is the maximum. So we're saying, okay, the absolute maximum heart rate is going to be 220 beats per minute. And then you just subtract the person's age, so minus age, to get what their maximum would be then. Okay? All right. So then we can take a little bit closer look at the heart rate and cardiac output. So initially, physiological conditions that cause heart rate to increase So let's say someone's exercising, right? So conditions, physiological conditions like exercising causes the heart rate to increase, also triggers an increase in our stroke volume. So as we start to exercise, I think that's what they say here. So during exercise, the rate of blood returning to the heart increases. So we start to run, let's say, then our heart rate is going to increase because the body is saying, like all of our muscles, right, we're running, all of our muscles are using up oxygen, and the body's saying we have to get oxygen to these muscles, they need it in order to keep running. So our heart rate increases. So our heart is pumping faster and faster and faster and faster in order to pump out more oxygen and more oxygen, more oxygen to get it to the muscles that need it. However, as the heart rate rises, so as we're running and our heart is beating faster and faster, at first, actually, before we get to that sentence, at first, the stroke volume is going to keep up with the heart rate. It's also going to increase because we're pushing that blood out of the heart, and we're also pushing it into the heart in the opposite side. So we're going to see this pushing in to the heart to get it back into the heart to get more oxygen, and a pushing out, and it's going to be increasing at the same rate. Then, as the heart rate keeps rising, so let's say we keep exercising more and more and more, then there is less time spent in diastole. So the faster our heart is beating, the less time it's relaxing. So it relaxes, fills up, squeezes it out. Relaxes, fills up, squeezes it out. And when it goes fast, it's relax, squeeze, relax, squeeze, relax, squeeze. And then that relax time is so short that we just don't get enough time to fill up those ventricles. So it's filling up as fast as it can, but it's just not enough time to let very much in. But then, even though there is less filling time, okay, so we're not getting as much in, so our stroke volume, in this case, in one single heartbeat is going to decrease, there's less filling time, then the stroke volume will initially remain high, okay? That was at the beginning, so it initially remained high, right? So our pushing in is going to equal the pushing out. And then we're going to increase and increase and increase our heart rate. That's when our stroke volume is going to start to decrease. So we have our decreased filling time. So we just don't have as much time to get as much blood in there because we're contracting again. So then in this case, the cardiac output is going to initially stabilize, okay, as the increasing heart rate compensates for the decreasing stroke volume, okay? So at first, let's get this straight, at first we have an increase in heart rate, so our heart is pumping faster. But it's pumping faster, it's also still allowing time for it to fill up with blood. So even though it's pumping faster, we're still getting enough diastole of the ventricles to fill up with blood. So our stroke volume is stable, our heart rate is stable, they're just both increased. We've increased, well, the stroke volume is the same, but we've increased our heart rate, stroke volume's fine. Then we increase our heart rate more. And at first, our stroke volume is going to be okay, our heart rate is going to be increasing, and then, even though we're going to have less time to fill up the ventricles, okay, we're going to have compensation. So our heart rate is going to be so fast that we're going to be pumping more even though we're pumping less blood every time. Okay, so if we pump, like, let's just say the number 20. Okay, so if our heart is beating and we're able to pump 20 units of blood in 1 minute, and then our heart rate doubles that. So let's say if we, that's a bad example. Okay. So let's just go back to the words here. I think they say it well. So the cardiac output will initially stabilize as the increasing heart rate compensates for the decreasing stroke volume. So we're not getting as much blood out every time we pump, but we're pumping more, so we're still getting the same amount of blood. There we go. That was nice and simple. So we pump more often, even though we're not pumping out as much blood, so our stroke volume is decreased, but our heart rate has increased in such a way to where we're still getting the same amount of blood out per minute. Okay? But then at very high rates, so we're getting up to this maximum amount, like the most the heart is going to be able to do, then our cardiac output will eventually decrease. So then at that point, we're getting so little time to fill our ventricles, our heart rate is going so fast that we're not getting that compensation. We're not getting enough beats of the heart to compensate for the fact that each beat is not pumping out that much blood. So at this time, then we're decreasing as increasing rates are no longer able to compensate for that decrease in stroke volume. So if you think about this in a healthy individual, initially their heart rate increases to approximately 120 beats per minute. Then our cardiac output is going to rise. As the heart rate increases from the 120 to 160, cardiac output remains stable because the increase in rate is offset by the decreasing ventricular filling time and consequently the stroke volume. Okay, so we have that compensation there. So even though it's beating really, really fast, we're getting enough blood in there to pump out, and it averages out for that minute. Then as the heart rate continues to rise above that 160, then the cardiac output actually decreases as the stroke volume falls faster than the heart rate increases. Okay, so now we're just not getting enough time to fill it up with blood, no matter how many times the heart beats to compensate for it. So although aerobic exercises are critical to maintain the health of the heart, individuals are cautioned to monitor their heart rate to ensure they stay within what's called the target heart range, or the target heart rate, which is a range between 120 and 160 beats per minute, so that that cardiac output is maintained. Okay, so this is something I think is very interesting when people talk about exercising and meeting this target heart rate. I think that it's important to note that this is an actual physical thing. It's not just something that people that exercise talk about, like, yeah, you got to make sure you do this many steps at this amount of time or anything like that. It actually relates to the volume of blood your heart is able to pump out compared to or in relationship to the heart rate. So the target heart rate is loosely defined as the range in which both the heart and lungs receive the maximum benefit from the aerobic workout, and of course that's dependent upon age. So you want to be in that target heart rate. So now that we've looked at the cardiovascular center, and we know that that's where these things are coming from, we can take a look at what input is going into that cardiovascular center to make that type of output. So the cardiovascular center receives input from a series of visceral receptors with impulses traveling through the visceral sensory fibers in the vagus and sympathetic nerves via the cardiac plexus. So if you remember back to the nervous system, the cardiac plexus is this region where all of these nerves are coming in near the heart. Among these receptors are proprioreceptors, so touch receptors, baroreceptors, which is a pressure receptor or stretching receptor, chemoreceptors, chemical-based receptors, and also stimuli from the limbic system, which is the emotional part of the brain. So collectively, altogether, these inputs enable the cardiovascular centers to regulate heart function precisely, and this is called cardiac reflexes. So these are the cardiac reflexes to allow that cardiovascular center to then regulate the heart rate, so increase or decrease based on the input from these different things that we'll be talking about. So increased physical activity results in increased rates of firing by different proprioreceptors located in muscles, joint capsules, and tendons. So the increase in exercise, that movement, the pushing and the flowing and the pushing on the muscles and the joint capsules and the stretching of the tendons, those kinds of things have proprioreceptors in them. And then the proprioreceptors are going to be firing when there's increased physical activity, for example, and then that information is going to go up to that cardiac center or cardiovascular center, and then that will increase the rate of firing, so it will increase the heart rate. So any such increase in physical activity would then warrant an increased blood flow. That's why it'll be increasing. So the cardiac centers monitor these increased rates of firing, and then they suppress parasympathetic stimulation. So remember, we're constantly sending that information like slow down, slow down, slow down to the SA node. In this case, So when we have these proprioreceptors picking up on this increase in movement, for example, then it's going to be sending messages like there's joint movement, for example, and stretching on tendons. That information goes to the cardiovascular center. The cardiovascular center then says, okay, we need to increase heart rate. We're going to do that by suppressing that message we're already sending to say, like, slow down, slow down. We're going to suppress the parasympathetic stimulation, and then we're going to increase the sympathetic stimulation. So then saying, okay, not only are we going to not slow down that SA node, we're going to increase the SA node. And then that will increase blood flow. So in that same way, we have baroreceptors, which are stretch receptors located in the aortic sinus, which is an area just above our aortic semilunar valve. The carotid bodies, which when we talk about blood vessels, you'll be familiar with those. They are kind of like an opening or a widening of the carotid arteries right before they branch off up in the head region. And there's a bunch of baroreceptors in there, stretch receptors, in the vena cava, so the vessels going up to our right atria, and then in other locations, including pulmonary vessels and the right side of the heart itself. So we have these stretch receptors in these areas, so that when the rates of firing from these stretch receptors they're going to increase, then that's going to send information to the cardiovascular center as well. So these baroreceptors, when they do stretch, right, that's going to represent an increase in blood pressure. So we've got these receptors, when they stretch because of an increase in blood pressure, then they're going to send a message. They're going to fire. So rates of firing from the baroreceptors represent blood pressure, level of physical activity. So if we have physical activity, we're pumping our blood more, it's going to increase our blood pressure. And the relative distribution of blood. So just generally sending information regarding where the blood is located is going to be part of the stretch receptor. So if there's more blood located in one part of the body, then the stretch receptors may be firing to say there's more blood here because of that stretch. The cardiac centers then monitor these baroreceptor firings to maintain cardiac homeostasis, which is called the baroreceptor reflex. So up here we have our cardiac reflex, because we're talking about our proprioreceptors in different regions. And then down here we're talking about our baroreceptor reflex, because we're talking about our baroreceptor firings. So with increased pressure and stretch, then the rate of baroreceptor firing increases. And then the cardiac center is going to again decrease sympathetic stimulation and increase parasympathetic stimulation. Okay, so if we have a baroreceptor firing, that means that there's a high amount of pressure there. And then the body says, oh boy, we've got high blood pressure, we need to decrease that blood pressure. So the cardiac center then is going to decrease our sympathetic stimulation. So it's going to decrease the heart rate and then increase our parasympathetic stimulation, which is saying that we're going to increase the one that says slow down, meaning we're going to be telling our heart to slow down, slow down, slow down that heart rate. So as pressure and stretch then decrease, the rate of baroreceptor firing decreases, and then the cardiac center increases the sympathetic stimulation and then decreases parasympathetic stimulation. So then it says, okay, we don't need that heart to slow down quite so much anymore. We're going to decrease the amount of times we're saying slow down, slow down, slow down, which then would increase the heart rate. Okay, so if we're then, I won't need to reiterate that, but then also we're going to do the opposite. We're going to increase our sympathetic stimulation, which remember is the one that says speed up, speed up. A similar reflex, then, we have our atrial reflex, also called the Bainbridge reflex, is associated with varying rates of blood flow to the atria. So we were just talking about blood flow to other regions, like the carotid sinus and things like that, but now we're talking about blood flow to the atria themselves. So if there's an increase in venous return, right, so return of blood via the veins into our atria, it's going to stretch the walls of the atria. And then there are specialized baroreceptors in the walls of the atria. And then as the atrial baroreceptors increase their rate of firing, so we have that stretch, which they're going to increase their rate of firing, and as they stretch due to the increased blood pressure, which of course is why they're firing, the cardiac center is going to respond by increasing sympathetic stimulation and inhibiting parasympathetic stimulation so that we can increase our heart rate. So in the case of in the atria, if we have a high amount of pressure in the atria, that means we have a lot of blood coming back to the heart. Our body is pushing through blood from our veins coming back into the atria. That means if we have a lot of blood coming into the atria, we need to get our heart pumping to get that moving through, to get it back into the lungs so that we can get more oxygen into the body. And if we have a whole bunch of deoxygenated blood, the way we can get more blood to have oxygen to get to the body again is to increase the heart rate. So we increase the heart rate by increasing our sympathetic stimulation and then decreasing or inhibiting our parasympathetic stimulation. So the thing's saying slow down. So instead we're saying speed up, and that will then increase our heart rate. And then, of course, the opposite is also true. So if we have a decrease in stretch in the atria, so let's say we've increased our heart rate, we're getting all that blood pumping in through there, and then let's say we stop exercising, we sit down, we're going to have a drop in the firing of those baroreceptors in the atria. So then we're going to do the opposite. We're going to decrease sympathetic stimulation. We're going to say, okay, we don't need to increase the heart rate anymore, so stop sending that message. And then we're going to increase our parasympathetic stimulation. So we're going to then go back to our, hey, slow down, SA node, slow down, slow down. Increased metabolic byproducts that are associated with increased activities such as carbon dioxide, hydrogen ions, and lactic acid, plus a falling in the oxygen levels, are then detected also by chemoreceptors. So we've talked about the baroreceptors, the proprioreceptors. Now we're going to talk about the chemoreceptors. So remember, chemo is because of chemical. So our chemical receptors are going to detect things like carbon dioxide in the blood, our hydrogen ions, lactic acid, and our falling oxygen levels. They're innervated by the glossopharyngeal and the vagus nerves, if you remember back to the nervous system. These chemoreceptors provide feedback to the cardiovascular centers about the need for increased or decreased blood flow, so based on the levels of these things. So if we have an increase in carbon dioxide, for example, our body's saying, oh, we're going to need more oxygen then, and so then we're going to increase heart rate. Same thing with lactic acid, with hydrogen ions, and falling oxygen levels. And then, of course, the opposite would be true. If we have our chemoreceptors noting the level of carbon dioxide and the level of carbon dioxide is very low, then we don't need to increase our heart rate. So we would need to decrease it, for example. Then lastly, we have our limbic system as far as the major groups here. So our limbic system can also significantly impact heart rate, and that's related to our emotional state. So during periods of stress, it is not unusual to identify higher than normal heart rates, often accompanied by a surge in the stress hormone cortisol. So individuals experiencing extreme anxiety may manifest panic attacks with symptoms that resemble those of heart attacks. So we're sending this information. So if we're stressed out, which is all just a personal thought process, we're creating that in our own brains. The limbic system will then send the information to the cardiac center saying, we're in a serious situation, we're going to need increased blood flow because, way back when, if there was stress, then that was likely due to something like a large animal coming at you. And so then the body would say, okay, if we're in a situation where we are concerned, if we are stressed, we're going to need an increase in heart rate. We're going to need an increase in oxygen because we're going to need to run. So then that will impact our heart rate very, very much. And then the opposite, of course, would be true as well. Nowadays, that's more of an issue, more of a problem. A lot of heart issues are related to that because we're no longer in a situation where the brain is in a state of stress because of some actual physical problem that's out there. Now it's just our thoughts that have made up this idea of stress. And so then it can lead to a constant state of stress, a constant state of us sending information saying speed up heart rate, which then can wear down the heart, increase blood pressure, and those types of things, increase our cortisol release, and then cause problems within the body. So these events are typically transient and treatable, talking about the panic attacks and extreme anxiety. And then, of course, people talk about meditation techniques to try to decrease this anxiety. And they've been shown to lower the heart rate effectively if people really stick to them and do them. Also doing simple, deep, slow breathing exercises with one's eyes closed can reduce this anxiety and can reduce the heart rate, because that's kind of, in a way, tricking the brain, the limbic system, to saying like, okay, now we're calm because we're not in a situation where a tiger is going to be running at us or something like that. So if we're able to close our eyes and take deep breaths, then our brain is going to say, okay, no more serious risk. We can decrease the heart rate. All right, so then we'll talk about some other factors influencing the heart rate. So let me actually back up just 1 minute. So in here, input, the major inputs, okay, are going to be things like the proprioreceptors, okay? So we talked about our proprioreceptors here, which when they are working on our cardiovascular center to regulate the heart rate. That's a process called cardiac reflexes. We talked about our baroreceptors. So the first one, proprioreceptors. The second one are baroreceptors. Baroreceptor reflex. Then down here, we talked about other baroreceptors, but those that are specific to being in our atria. So this would be called the atrial reflex or the Bainbridge reflex. And then we also have our chemoreceptors right here, our chemoreceptors that are sending information regarding carbon dioxide, hydrogen, lactic acid, and oxygen levels. And then lastly, we have the limbic system, which is based on emotion and stress. So then we're going to take a look at some other factors that are going to be influencing the heart rate. All right, so now we're going to talk about things that are not related to the cardiovascular center specifically. So those were receptors that were going through nerves that were going to the cardiovascular center and initiating or increasing or decreasing the flow in the sympathetic or parasympathetic nervous system. So now we're going to talk about things that are outside of that. So using a combination of autorhythmicity and innervation. So the cardiovascular center is able to provide relatively precise control over heart rate. So those are the things that we just talked about. However, there are other factors that have an impact on heart rate. So the first one is epinephrine and norepinephrine. And then we have thyroid hormones. Then we have the levels of different ions, including calcium, potassium, and sodium, all three of which are part of our depolarization, repolarization in the plateau. Body temperature, hypoxia, which is low oxygen, and pH balance, so being acidic or alkaline. So after reading this section, we're going to see homeostasis. So at first what we're going to do is we're going to skip these charts, and then we can come back and take a look at them. They're a nice little summarization. But let's just read through here the paragraphs and talk about them, and then we can go back and look at those. So first, epinephrine and norepinephrine. So these are catecholamines. Epinephrine and norepinephrine are secreted by the adrenal medulla, so in the medulla right above the kidneys. They form one component of our extended fight or flight mechanism. The other component is the sympathetic stimulation that we've already spoken a lot about. So epinephrine and norepinephrine have similar effects. They work similarly. They bind to beta-1 receptors, and then they open sodium and calcium ion chemical or ligand-gated channels. Okay, so the beta-1 receptors are going to be opening up those sodium channels to allow that influx of sodium that's going to bring us up to or have that sharp rise in our action potential, doing the depolarization. And then remember, calcium is a part of our plateau, so calcium ion is important during that plateau period to allow our ventricles to fill up before we then repolarize. The rate of depolarization is increased by this additional influx of positively charged ions, so the threshold is reached more quickly, and the period of repolarization is then shortened. Okay, so when we're talking about epinephrine and norepinephrine, what we're doing is we have this increase in calcium and increase in sodium, and since we have an increase in these ions, then we're going to go through the depolarization process much faster because we have so many sodium ions, for example, and then our repolarization is going to shorten. It's not going to take as long because we've got another influx of sodium ions. However, massive releases of these hormones coupled with sympathetic stimulation may actually lead to arrhythmia, so that can kind of get all messed up if we have too much of that happening. There is no parasympathetic stimulation in the adrenal medulla. So the adrenal medulla does not affect the parasympathetic section of our cardiac center. All right, so then next were the thyroid hormones, specifically T3 or triiodothyronine or thyroxine. So the active form of the thyroid hormone is T3 or triiodothyronine. So if we have increased levels of the thyroid hormone or thyroxine, it can increase cardiac rate and contractility. So again, if we have an increase in our thyroid hormones, we have an increase in heart rate. The impact of thyroid hormone is typically of a much longer duration than that of the catecholamines. So when we have our epinephrine and norepinephrine, that's a shorter reaction. That's a very quick response that's going to increase our heart rate. This is more long-term. Okay, so we're releasing these hormones, it's more long-term. So the impact of thyroid hormone is typically of a much longer duration. The physiologically active form of the thyroid hormone, here I already mentioned that, triiodothyronine, has been shown to directly enter the cardiac cells, the cardiomyocytes, and alter the activity at the level of the genome. So it takes longer, it's not as quick. It also impacts the beta-adrenergic response, similar to epinephrine and norepinephrine, as we just described. So it does impact that, but it also goes all the way down into the heart cells to affect them genetically. And then excessive levels of thyroxine may trigger tachycardia. So if we have an increase in thyroxine and an increase in heart rate, if we have an extreme level of our thyroid hormone, if we're releasing lots and lots of it, if there's some sort of thyroid issue, then we would have this extreme increase of heart rate, and then that would be tachycardia. Calcium ion levels have great impacts upon both heart rate and contractility. So as the levels of calcium ions increase, so do heart rate and contractility. So high levels of calcium ions, which is called hypercalcemia, may be implicated in a short QT interval. So our shorter QT interval, which is going to go through heart rates faster, and a widened T wave in the ECG. So remember, the QT interval is the time from the start of depolarization to repolarization of the ventricles. And remember, that's where we saw calcium. That's where it was important, was during that plateau phase. So if our QT interval is going to be shortened, then the time from the start of depolarization to repolarization of the ventricles is going to be shortened. And this includes the period of ventricular systole, which, remember, ventricular systole is when we have that contraction. So extremely high levels of calcium may induce cardiac arrest. Drugs known as calcium channel blockers slow heart rate by binding to these channels and blocking or slowing this calcium movement in, so that we can then have a better heart rate. So if somebody has high levels of calcium, they can take medications to bring their heart rate down by preventing this calcium from going in. Caffeine, that's my mix. That's caffeine and nicotine. I'm going to start selling that. Caffeine and nicotine are not found in the body naturally. Both of these non-regulated drugs have an excitatory effect on membranes of neurons in general and have a stimulatory effect on the cardiac center specifically. So they cause an increase in heart rate. So they're excitatory, increase in heart rate. Caffeine works by increasing the rates of depolarization at the SA node. Okay, so caffeine is directly getting to that SA node. Not really getting to the SA node, but increases the rates of depolarization at that SA node versus nicotine that is going to stimulate the activity of the sympathetic neurons that then are going to deliver impulses to the heart. So caffeine is working more at the heart location, the SA node, versus nicotine, which is working at the brain or the cardiac center, that then goes to the heart and tells it to increase. Although it's very common, caffeine is legal, not regulated. Precise quantities have not been established. Normal consumption is not considered harmful to most people, but it could cause disruption in sleep. It also acts as a diuretic, so caffeine increases the loss of fluids in the body, so you could have decrease in blood pressure, which could then increase heart rate as well, because if you have a decrease in blood pressure, the heart's going to try to make up for it. Consumption by pregnant women is cautioned against, although there hasn't really been anything confirmed. Tolerance and even physical and mental addiction to caffeine results in people who regularly consume the substance. And of course, we see that in nicotine as well, as a stimulant and produces addiction. Also legal, not really regulated. Concerns about the safety and documented links to respiratory and cardiac disease have made it so there are warnings on cigarette packages. So nicotine, there is a direct connection between that, and they say that that can be so damaging that they are looking at ways to portray that and get that across, although in caffeine not as much. All right. So now let's take a look at some of the factors that are decreasing heart rate. Okay. So heart rate then can be slowed when a person experiences altered sodium and potassium levels, hypoxia, which is decreased oxygen, acidosis, alkalosis, and hypothermia. So let's take a closer look at each of those. So the relationship between electrolytes and heart rate is complex. Electrolytes are very important for heart rate, but maintaining electrolyte balance is critical to the normal wave of depolarization, right? So if we're talking about ions, right? So electrolytes are ions, are sodium, potassium, and calcium. And all three of those we see very specifically in our depolarization and repolarization. So they're incredibly important to our heart rate. So of the two ions, when we're talking about sodium and potassium, because we already talked about calcium in the increase in heart rate. So sodium and potassium actually has the greater clinical significance. It's more important to look at potassium levels and see a difference there. So let's first look at sodium and then we'll look at potassium. So initially both hyponatremia, which are low sodium levels, and hypernatremia, which are high sodium levels, both lead to tachycardia, which is an increase in heart rate. So low sodium levels, because we would have a decrease in blood pressure. Remember, sodium is going to be pulling water into the bloodstream. So if you have a very low amount of sodium in the bloodstream, then you're keeping your water in your tissues, and so then you're going to have a decrease in blood pressure. So we're wanting to increase that blood pressure, so we'll see an increase in heart rate. Hypernatremia, which are high sodium levels, we'll start seeing, since there's so much sodium in the system, yes, you will have an increase in blood pressure. However, at the same time, if there's that much sodium in the bloodstream, we will see an increase in heart rate because of the increase in sodium in the depolarization process. So lots of sodium going into the cell is going to depolarize very quickly and lead to an increase in heart rate and tachycardia. Severely high hypernatremia, so high amounts of sodium, may lead to fibrillation, which may cause cardiac output to cease. So much sodium is just going to be constantly trying to depolarize the heart cells, and if it's just not getting the chance to go through that plateau phase to fill up with blood and not be able to even repolarize, then it's just going to totally be done, give up. So severe hyponatremia leads to both bradycardia, so if you have a decrease in sodium, at first it'll try to increase heart rate because it'll have a decrease in blood pressure, but then after that you're going to have so little sodium in the body. If it's severe, then you're not going to be able to depolarize because you don't have the sodium rushing into the cell to be able to go up to depolarization or go through depolarization. So we'll have a bradycardia, which is a slowing of the heart rate, and other arrhythmias. Hypokalemia, kalemia is related to potassium, and hypo meaning low, low potassium levels, also leads to arrhythmias. So if we don't have the potassium, remember potassium has to leave the cell in order for repolarization to occur. Will lead to some difficulties or some changes in our ECG, our arrhythmias. Whereas hyperkalemia, which is high potassium levels, cause the heart to become weak and flaccid and ultimately to fail. So if you have an extreme amount of potassium in your bloodstream, then we're not going to see the flow of potassium from the cell leaving to go through repolarization. And so then what we see is this potassium is not going to be moving back and forth to have us go through depolarization and then repolarization. And so then the heart basically just becomes weak and ultimately doesn't pump anymore. Acidosis is when we have excess hydrogen ions and then the blood is a low pH, acidic. Alkalosis is where there are too few hydrogen ions and an elevated pH, so alkaline. Normal blood pH is 7.35 to 7.45. So a number lower than this would be acidosis, more acidic. A number higher then would be alkalosis, which is more alkaline. And then the reason for this, the reason why acidosis and alkalosis is a problem for the heart is more specifically related to enzymes. So if you remember, enzymes are the regulators or catalysts of virtually all biochemical reactions. They're sensitive to pH, and then they will change shape slightly with values that are outside their normal range. So the enzymes inside of our system, inside of our body, need to be in this appropriate range here of 7.35 to 7.45. If we get extremely acidic or extremely alkaline, then our enzymes will actually change shape and then they will no longer function. So these slight physical changes to the active site on the enzyme are going to decrease the rate of formation of our enzyme substrate complex. And then it will decrease the rate of our enzymatic reactions, which then in many ways that we won't go into in details will have an effect on the heart rate. Severe changes in pH then can lead to a complete denaturing of the enzyme to where the enzyme does not even form anymore and it doesn't function at all, which then would lead to heart rate totally stopping. So our last variable is temperature, body temperature. Elevated body temperature is called hyperthermia, and suppressed body temperature is called hypothermia. So a slight hyperthermia results in an increase in heart rate and strength of contraction, because what we're trying to do at this point, if we're hot, hyperthermia, we are going to be pumping blood to try to get it to our extremities to cool it down. So we're trying to push the blood out to all of our capillaries that are close to the surface of the skin to release that heat into the exterior. Hypothermia, so decrease in temperature, slows the rate and strength of heart contraction. So at that time we're saying we don't want blood to get to our extremities because we don't want to lose any more heat. And we keep our blood closer so we decrease our heart rate to not push as much blood out to our capillaries and our extremities. So we keep it close to try to make sure that the main and major parts of our body stay functioning, so the stuff in our torso. So this distinct slowing of the heart is one component of the larger diving reflex that diverts blood to essential organs while submerged. So we see this when somebody dives, and all of the blood flow is going to stay in these major areas in the torso. If sufficiently chilled, the heart will actually stop beating because it doesn't want to send the blood out to get more cooled down, and then it'll just be too cold for it to function. They employ this technique during open heart surgery. So the patient's blood is normally diverted to an artificial heart-lung machine to maintain the body's blood supply and the gas exchange while the surgery is complete. When they're working on the patient's heart, they cool it down to where it will stop beating so they can work on it, and then they allow the blood to continue flowing through the person's body using this artificial heart-lung machine. And then until the sinus rhythm can be restored. So excess hyperthermia, so being extremely hot, and hypothermia, being extremely cold, will both result in death. So if you get too hot, your enzymes will just boil and break apart, and then they won't function anymore and you will die. Extreme hypothermia, your heart stops beating, and then of course you're not getting oxygen and blood to all your tissues, and then that results in death as well. Because enzymes drive our body systems. And if they're not working anymore, then we don't work anymore. All right, so if we go back up to the charts here, let's see. So then all of what we just spoke about is summarized in these charts. So we have our cardio accelerator nerves, here, and then it talks about the effect. So these are major factors that are increasing heart rate and force of contraction. So cardioaccelerator nerves, how they do that. Proprioceptors, how that's done. So you should know all of these things. We just spoke about them. We talked about the different ions here, the catecholamines, thyroid, our limbic system. So that's a continuation of the chart. Increasing heart rate. And then here we are, factors that decrease heart rate and the force of contraction and the things that we've just spoken about. So this is a good little study tool here to go through, and then if you are not remembering what they mean by that, you can go into the paragraph and then take a look at what we've already discussed. So now we're going to talk about this last section here is stroke volume. So many of the same factors that regulate heart rate also impact cardiac function by altering stroke volume. So a number of variables are involved, but it's ultimately dependent upon the difference between the EDV and the ESV. Remember, EDV is end diastolic volume, and ESV is end systolic volume in the ventricles. So end diastolic volume, remember, that's the amount of blood that we have in there before, or in the ventricles, before the atria squeeze blood into the ventricles. So it's just what naturally poured in there from the inferior and superior vena cava, for example, on the right side. So what normally pours in there before the atria have contracted. ESV is what is left in there after ventricular contraction. Okay, so then the difference between the two, right, would be stroke volume, the amount that comes out. So the three primary factors to consider are preload, which is the stretch on the ventricles prior to contraction, the contractility, so the force or strength of the actual contraction. So preload is 1, the stretch of the ventricles, contractility, or the force of the contraction, is 2, and then afterload is the third one, which is the force the ventricles must generate to pump blood against the resistance of the vessels. So this is more systemic, so related to the vessels specifically. All right, so let's talk about preload first. So preload is another way of expressing our end diastolic volume, or the amount of volume of blood in there before our atria have contracted. So the greater the EDV is, the greater the preload is. So one of the primary factors to consider is filling time. So if you have a longer filling time, then you would have a greater EDV. So filling time is the duration of ventricular diastole, so while it's at rest, and that's when filling occurs. So the more rapidly the heart contracts, the shorter the filling time, the lower the EDV, not as much time to get blood in there, and then that would mean a lower preload. It can be partially overcome by increasing the second variable, contractility, and raising the stroke volume, but over time the heart is unable to compensate for the decreased filling time, and then preload will also decrease. And we spoke about that a little bit earlier when we talked about kind of our output compensating, our heart rate increasing and how it compensates at first, and then it doesn't compensate anymore, it can't. So with increased ventricular filling, both EDV or preload are going to increase, and the cardiac muscle itself is stretched to a greater degree. So we see more stretching because it's filling up with more and more blood, and so it's stretching out. At rest, there is little stretch of the ventricular muscle, so not much stretch, and the sarcomeres are going to remain short. Okay? With increased ventricular filling, then, the ventricular muscle is increasingly stretched, and the sarcomere length is going to increase. As the sarcomeres reach their optimal lengths, they will then contract more powerfully because we get more of those myosin heads that can bind to the actin on the thin filaments and form those cross bridges, and then they can pull to do the contraction. So it increases our strength of contraction and our stroke volume. However, if this process were to continue, if we keep increasing the length of the sarcomeres, keep stretching them beyond this optimal length, then the force of contraction would decrease because we wouldn't have then this matchup between the myosin heads and the actin to be able to have a great strength of contraction. That said, due to where the actual location of the heart is, it's surrounded by our lungs, we don't really have this problem. It's not much of a concern. We don't have the space to have this extreme stretching. So the relationship between the ventricular stretch and contraction has been stated in the Frank-Starling mechanism, or Starling's law of the heart. So this principle states that within physiological limits, the force of heart contraction is directly proportional to the initial length of the muscle fiber. So that means that the greater the stretch of the ventricular muscle, within limits of course, the more powerful the contraction is. So the more myosin heads are able to attach the actin filaments and make a powerful contraction, which in turn then increases our stroke volume. So therefore, by increasing preload, you increase our second variable, which is contractility, the force of strength there, or the force of the contraction. Otto Frank is part of that. So Frank Starling, Otto Frank is a German physiologist, and then Ernest Starling, an English physiologist. So any sympathetic stimulation to the venous system will increase venous return to the heart, so increase the blood going into that right area, and of course the other atria, but which contributes to ventricular filling and EDB or preload. So if we have some stimulation that increases our venous return to the heart, then we're going to have a greater EDB or preload. While much of the ventricular filling occurs while both atria and ventricles are in diastole, the contraction of the atria, the atrial kick, then plays a crucial role because it adds the last 20 to 30% to our ventricular filling. So then the second one was contractility. So remember, contractility is how strong of a force of contraction is. So the force of contraction of the heart muscle. So these two parameters are linked. So talking about preload, or how much blood is in there, or ESV, ahead of time is directly related to contractility, or the force of contraction. So the force of contraction, or contractility here refers to the force of contraction of the heart muscle, which controls our stroke volume, right? So if we have a weak contraction, we're not going to get much stroke volume. If we have a very forceful contraction, we'll have a lot of stroke volume, a lot of blood leaving. So it's the primary parameter for impacting our ESV, which is how much blood is left in the heart after contraction. The more forceful the contraction, the greater stroke volume, smaller ESVR, the smaller blood left in the heart. Less forceful contractions result in smaller stroke volumes and larger ESVs. So factors that increase contractility are called positive inotropic factors. Ino meaning fiber, and tropic turning toward, and then positive, so an increase. And those that decrease contractility are negative inotropic factors. So then this paragraph kind of just summarizes or talks about some of the things we already spoke about. So sympathetic stimulation is a positive inotrope, right? So remember, sympathetic stimulation increases heart rate, so it's going to be positive, which is going to also increase the strength of contraction. Whereas parasympathetic stimulation, remember that decreased heart rate, it's a negative inotrope, so it's also part of decreasing our contraction. Sympathetic stimulation triggers the release of norepinephrine at the neuromuscular junction from the cardiac nerves, and also stimulates the adrenal cortex to secrete epinephrine and norepinephrine. So we're talking about sympathetic, our positive inotrope. We're talking about epinephrine and norepinephrine, our catecholamines. So in addition to their stimulatory effects on heart rate, which we already talked about, they also bind to both the alpha and beta receptors on the cardiac muscle cell membrane, and then they increase the metabolic rate and the force of contraction. So because they increase the heart rate, or not because, but they increase heart rate, and they also attach to these alpha and beta receptors, and then they increase the contractility of the heart. So they have a net effect of increasing our stroke volume and leaving a smaller ESV in the ventricles. And then on the other side of that coin, we have our parasympathetic stimulation, which releases acetylcholine at the neuromuscular junction from the vagus nerve. The membrane hyperpolarizes, that's getting more and more negative than it normally does, and inhibits contraction to decrease the strength of contraction and stroke volume and raise ESV. Okay, so it takes longer to go through depolarization at that point because it hyperpolarizes it. Since parasympathetic fibers are more widespread in the atria than in the ventricles, the primary site of action is in the upper chambers. Then parasympathetic stimulation in the atria decreases the atrial kick, reduces the EDB, so it's not forcing as much blood down into the ventricles, It also reduces EDB, which decreases the ventricular stretch and preload, so we have less in the ventricles before they contract, and thereby further limiting the force of ventricular contraction. So if there's not as much blood, it's not going to contract as forcefully, not going to get as much stroke volume. Stronger parasympathetic stimulation also directly decreases the force of contraction on the ventricles. So it even very specifically goes to the ventricles and decreases the force of contraction. It talks about several synthetic drugs, dopamine and isoproterenol, which have been developed to mimic the effects of epinephrine and norepinephrine, so stimulating the influx of calcium ions from our extracellular fluid. Higher concentrations of intracellular calcium ions increase the strength of contraction. Excess calcium, or hypercalcemia, also acts as a positive inotropic agent, so a stronger contraction. The drug digitalis lowers the heart rate and increases the strength of contraction, acting as a positive inotropic agent by blocking the sequestering of calcium ions in the sarcoplasmic reticulum. So it allows those to get out of there, which then is going to increase the strength of contraction. It leads to a higher intracellular calcium level and greater strength. In addition to the catecholamines from the adrenal medulla, other hormones demonstrate a positive inotropic effect, including the thyroid hormones and glucagon coming from the pancreas. So then we have negative inotropic agents. So they look similar to what we've already spoken about relating to heart rate. So negative inotropic agents, hypoxia, acidosis, hyperkalemia, and other synthetic drugs. So include numerous beta blockers that don't allow that exchange. It's going to decrease the contraction strength. Calcium channel blockers, so we have a decrease in contraction strength. So early beta blocker drugs include propranolol and pronatholol, and are credited with revolutionizing treatment of cardiac patients experiencing angina pectoris. So there's also a large class of dihydropyridine and phenylalkylamine and benzothiazepine calcium channel blockers that may be administered, and they also decrease the strength of contraction and then decrease the stroke volume. So these are the drugs here, the synthetic drugs. So when we're talking about negative inotropic agents, low oxygen here, acidosis, hyperkalemia, and then these synthetic drugs that were just mentioned in these two areas here. So then remember, the third part of the stroke volume that we're talking about is afterload. So afterload refers to the tension that ventricles must develop to pump blood effectively against the resistance in the vascular system. So what they're working against here is called the afterload. So any condition that increases resistance requires a greater afterload to force open the semilunar valves and pump the blood. So an increased resistance, so any condition that increases resistance. So if we have a roughening up or atherosclerosis, for example, in our arteries, then we would have to have a greater afterload, an increase in force to force the blood into the system because of that increased resistance. So for example, damage to the valves, such as stenosis. So if we have valve damage, also stenosis is a decreasing in size of the vessels. So for example, if you have atherosclerosis, the diameter of our vessels will be decreased. Makes them harder to open, makes the valves harder to open, and will also increase afterload. So not only just in the vessels, like say the pulmonary trunk or the aorta, but also right in those specific areas of the valves. So damage to our semilunar valves are going to have an effect on afterload. So any decrease in resistance is going to decrease the afterload. So if we are all healthy, we don't have any atherosclerosis, we don't have any roughening up of our arteries, then things are going to go nice and smooth, and it's going to decrease our afterload. All right, so then we have these charts here. Another good way to summarize the information. So talking about the preload, the contractility, and the afterload. So these are factors that are affecting stroke volume. Again, these three things. And it talks about raised or lowered for each of these. And you should know those things as well. All right, so then that is actually up, and here's another one, a summary of the factors. So this is factors affecting the heart rate, which we talked about. There's a little summary here. Factors affecting the stroke volume, and then again our equation here, our cardiac output is the heart rate here times the stroke volume, and all the different things that are going to affect both sides of that equation, or both factors in this equation. All right. Cardiac response, decreasing blood flow and pressure due to decreasing cardiac output. So this is another way to summarize things. So the baroreceptors, chemoreceptors, what they're sensitive to, what their target is, their response, and overall effect. So just another way to summarize the information that we just talked about. So perhaps looking at all of these different charts, kind of writing them out, will help you to remember all of the different effects on this. And then this is another chart due to increasing, talking about the baroreceptors, sensitivity, target, response, and overall effect. As far as 19.5, I'm not going to go through the development of the heart. We're going to focus more so on the rest of the chapter and talk about the heart as it is rather than development of the heart.